Maybe we'll get started. So my name's Tim Pawlik, and I'm from Ohio State. Dr. Feng Shen sends his regards. Unfortunately, he wasn't able to make it here this morning, so I'm going to be doing this by myself. So I thought I'd go over intrahepatic cholangiocarcinoma, for about, 20, 25 minutes, and then we can have an opportunity to discuss some of the relevant topics. So as you all know, intrahepatic cholangiocarcinoma represents 1/4 of all cholangiocarcinomas. And I'm going to go over cholangiocarcinoma, intrahepatic cholangiocarcinoma using this outline. And I had the opportunity a couple years back to participate as one of the experts on the panel that ILCA set up, International Liver Cancer Association, to help develop practice guidelines in intrahepatic cholangiocarcinoma. ILCA had noted that there has been an explosion in the literature around intrahepatic cholangiocarcinoma, and with the increased interest in the disease, they thought it was an appropriate time to gather a panel of international experts to come up with some practice guidelines. These guidelines are published in the Journal of Hepatology, and I'll be largely basing my comments off that article. So the first thing I was going to talk about is a little bit about the epidemiology and risk factors for intrahepatic cholangiocarcinoma. So ICC is actually on the rise. And the reason for that is multifactorial. We know that the population is aging worldwide, and especially in the United States. And like most malignancies, there is an age association with this cancer. There is a very dramatic worldwide variation in the incidence of intrahepatic cholangiocarcinoma. And as you all know, it's not surprising that in Eastern countries, the incidence of intrahepatic cholangio is dramatically higher. You can see here in Shanghai, where Dr. Shen is from, the incidence can be as high as 7 to 8 per 100,000, whereas in the United States, it's only about 2 per 100,000. Interestingly, at least in the United States, when we look at some epidemiologic data, while we typically think of extrahepatic cholangiocarcinoma, perihilar cholangiocarcinoma being the most common cholangiocarcinoma, it appears that the incidence of extrahepatic cholangiocarcinoma is decreasing, while the incidence of intrahepatic cholangiocarcinoma is increasing. Now, the reason for this is probably multifactorial. Some of this is probably due to a diagnostic, probably misclassification bias. Back in the 70s and 80s, our hepatopathologists weren't quite as sophisticated as they are now. And there were many patients who were diagnosed with adenocarcinoma not otherwise specified in the liver that probably were really intrahepatic cholangiocarcinoma. But now, with more sophisticated immunohistochemical techniques, our hepatopathologists are much more comfortable reading out specimens from liver biopsies, adenocarcinoma, most probably of biliary tract origin. So some of this is probably simply a misclassification, but it's probably true that there is a true increase in the incidence of this disease, at least in some areas of the world. And that is probably related to some of the risk factors associated with intrahepatic cholangiocarcinoma, and you can see those listed here. Some of these risk factors are obviously somewhat geographically specific, such as hepatobiliary flukes, which tend to be much more common in Eastern countries, and also choledochal cysts, which again tend to be more common in Asia. Other things, however, such as obesity and diabetes, becoming more and more prevalent, especially in Western countries in the United States. And similarly to how NASH or NAFLD is strongly associated with hepatocellular carcinoma, there is evidence from our group and others that the finding of non-alcoholic steatohepatitis is a risk factor for patients to develop intrahepatic cholangiocarcinoma. And I would say that it's not uncommon, or in fact maybe one of the most common presentations, at least in my clinic, to have a middle-aged obese woman present with a steatotic liver with an intrahepatic cholangiocarcinoma. So I do think with the epidemic of obesity and NASH that this indeed is associated with the increased rise in intrahepatic cholangiocarcinoma that at least we're seeing in the US. I wanted to touch a little bit on some of the molecular pathogenesis of intrahepatic cholangiocarcinoma. There's multiple different pathways that are involved in the pathogenesis of this disease, including EGFR, also the RAS pathway, and RAF. About 3 or 4 years ago, using our international collaboration, we were able to collect a number of specimens from resected tumors, and we sent them to our collaborator and colleague, Andrew Zhu, who's at the Massachusetts General Hospital, and we did a genetic analysis of these resected tumors. And at least on this assessment, we found that there were no somatic mutations present in about 62% of patients. And then the most common genes that we found to be mutated, no surprise, was IDH1 or IDH2, which was mutated in about 20% of patients, and then KRAS and BRAF that was mutated in roughly 5 to 10% of patients. And obviously we know that KRAS and BRAF are important genetic mutations when it comes to other GI tumors such as colorectal tumors. We also know that IDH1 and IDH2 play an important role in intrahepatic cholangiocarcinoma. And as I'll show you, these genes are important not only for prognostic purposes, but are being increasingly targeted for therapeutic purposes among patients with intrahepatic cholangiocarcinoma. As I alluded to, these genetic mutations can have prognostic implications. Here's a study that was published by Dr. Anders at Johns Hopkins while I was there, looking at KRAS and BRAF mutations, and perhaps not surprisingly, those individuals who had mutations in KRAS and BRAF had a median survival of only roughly 1 year. Here's another study that was published in Nature Genetics, in which we performed whole exome sequencing of intrahepatic cholangiocarcinoma. And in this study, we looked at the prognostic implications of IDH mutation. And you can see here that patients who had IDH mutation did significantly worse, with a median survival of just around 2 years. The other thing that is obviously a hot topic is immunotherapy. And we've done some very preliminary work looking at PD-1 and PD-L1 in patients with intrahepatic cholangiocarcinoma. And here's an image looking at the interface between the tumor and the regular liver. And at least in this study, we found that there was staining in a subset of patients for PD-1, suggesting that PD-1 therapy may indeed be potentially important in a subset of patients with intrahepatic cholangiocarcinoma. So in light of those data, as I mentioned, not only are these genetic mutations prognostically important, but they are increasingly being targeted as possible therapy. And there's a number of trials that are currently opened in the US, dasatinib for patients who have an IDH mutation. There's other trials looking at patients who have MSI-high intrahepatic cholangiocarcinoma, pembrolizumab for those patients. And then there are other studies identifying patients who have mutations or dysregulations of FGFR with novel specific targeted agents. So this is a disease with a grave prognosis. And I think it's very important that we try to enroll patients in clinical trials, and we try to focus on personalized therapy for these patients. And I think, at least from my perspective, it's encouraging that there are at least some trials that are open for patients with this challenging disease. So how about the clinical diagnosis of intrahepatic cholangiocarcinoma? Well, this group doesn't need me to tell you that these patients present very differently than patients with perihilar or distal cholangiocarcinoma. Frequently, these patients present incidentally. They may come to the ER for some other reason, and at least in the United States, cross-sectional imaging is ubiquitous. Virtually everyone gets a CT or an MRI if they're feeling even a little ill, and it's not uncommon that a patient will present with a relatively asymptomatic mass, such as this one, in segments 5 and 6 next to the gallbladder. And typically what happens is someone sticks a needle in it. And when a needle gets stuck in it, it then comes back as adenocarcinoma. And there's really no reliable markers to differentiate intrahepatic cholangiocarcinoma from metastases 100%, but some of the things that the pathologists look for are biliary dysplasia. And then on IHC staining, there's a specific pattern that one should look for. So typically negative for TTF1, CDX2, and DPC4, helping to rule out lung, colon, or pancreas origin, and then positive for CK7 and AE1, AE3, suggesting biliary epithelium. I would suggest, we all know this as surgeons, is that not every tumor needs to be biopsied, and if something looks suspicious for cancer and it's resectable, I usually just take it out after working the patient up. And I really think that probably biopsy is oversubscribed, especially in a patient such as this one where this looks resectable. Because even if the biopsy was negative here, we would still take this out. So the question is, why even biopsy it if you do a workup and there's no metastatic disease? I would just proceed directly to surgery. The other thing that I frequently tell medical students and residents is that we cannot rely on preoperative laboratory work and tumor markers. Tumor markers tend to be very specific but not very sensitive. And even in patients who may have advanced intrahepatic cholangiocarcinoma, half of them will not have an elevated CA19-9. So it is not sensitive enough to be using this as a diagnostic marker of the disease. When patients present with a tumor in their liver that has been suggested to be an adenocarcinoma, I make sure that other potential primary sites have been excluded. If the patient is a woman, I would make sure that they've had a recent mammogram. I selectively use upper and lower endoscopy. I can remember one patient who was referred to me for an intrahepatic cholangiocarcinoma, that even the pathologist thought that perhaps it was an intrahepatic cholangiocarcinoma, and then we found a gastric primary in the stomach on upper endoscopy. So I think that I at least want their lower endoscopy to be up to date, and then depending on the clinical exam and the history, I selectively use upper endoscopy. But really the workhorses for the workup of intrahepatic cholangiocarcinoma will be cross-sectional imaging, either with CT or MRI, and then I actually use a fair amount of PET scan for this disease. Now, when considering cross-sectional imaging, it's important to know that there's 3 different morphologic subtypes of intrahepatic cholangiocarcinoma. Typically, we're talking mostly about the mass-forming subtype, and as you can see here, this presents with a low attenuation lesion and capsular retraction, and then peripheral enhancement of the tumor. The periductal infiltrating subtype of ICC typically presents with this periductal enhancement, with periductal thickening, and then irregular intraductal dilatation, as can be seen here. And then finally, the intraductal growth subtype can present with ductasia, as can be seen here, and then sometimes this intraductal cast-like lesion. On CT scan, the mass-forming lesions typically present as an irregular low attenuation mass. And in experience, hepatoradiologists can quite easily typically differentiate between a hepatocellular carcinoma from an intrahepatic cholangiocarcinoma. Because as we all know, hepatocellular carcinoma usually enhances early and then has late washout, right? That's what the classic, right? Arterial enhancement, late washout. Because that is a soft tumor in a fibrous, hard liver. Well, intrahepatic cholangiocarcinoma tends to be the opposite. It is typically a fibrous tumor, a hard tumor, and a softer steatotic liver. So for intrahepatic cholangiocarcinoma, typically you see late enhancement. So early on it's hypoattenuated, and then later on you have enhancement. And also you can see this on the MR, and I tend to prefer MRI over CT. And on this MRI, you can see some of the sine qua non, if you will, of intrahepatic cholangiocarcinoma. You can see the capsular retraction. You can see the peritumoral ductal dilatation. And then here you can see the tumor with central necrosis, and the enhancing rim, which would all be very strongly suggestive of ICC. As I mentioned, I tend to use PET actually a little bit more even with intrahepatic cholangiocarcinoma than I do for colorectal liver metastasis. And the reason for this is that this disease is very FDG avid, and at least on the little amount of literature that is available, cult metastatic disease will be noted in about 20 to 30% of patients, and this may lead to a change in surgical management in about 30% of individuals. And some of this is because, as I'll show you, those patients who have preoperative evidence of nodal metastases have a particularly grave prognosis. So one might give consideration for preoperative chemotherapy to let the biology of the disease sort itself out before embarking on liver resection. One particular interest of mine over the last decade has been the staging for intrahepatic cholangiocarcinoma. As many of you know, there was no staging for intrahepatic cholangiocarcinoma in the first 6 editions of the AJCC-UICC classification system. Basically, ICC and HCC were shared the same staging system. There was like one sentence that said, use the same staging system for intrahepatic cholangiocarcinoma. But there's no reason to empirically think that these are the same diseases, which they're not. So why should they have the same staging system? And they probably shouldn't. There have been 2 Japanese groups that had proposed distinct staging systems for patients with intrahepatic cholangiocarcinoma, but these had never been widely adopted in the West, nor had they been validated in the West. So in 2010, one of my research residents at the time, Dr. Hari Nathan, and I embarked on looking at this, and we proposed a simplified staging for patients with intrahepatic cholangiocarcinoma and stratified patients with regards to T1, T2, and T3 disease among those patients who were N0, M0. And our proposed staging system had an incremental increase in the hazard of death, as one would want with the T categories, unlike the 6th edition AJCC staging, as well as unlike the 2 proposed Japanese staging system. The other thing that we were interested in was this idea of lymphadenectomy. So after kind of thinking about the T disease and establishing that, we wanted to establish whether one needed to assess the nodal basin. And at that time, our international group had about 500 patients in the data set. Now we have well over 1,000, but at that time we had about 500. And what was interesting to see is that even in very experienced hepatobiliary centers worldwide, whether one got a lymphadenectomy was really the flip of a coin. It was 50-50 whether a lymphadenectomy was performed or not at the time of liver resection. The other thing that was interesting is that the nodal harvest was about 3 lymph nodes, consistent with most of the literature for other lymphadenectomies for things like a radical cholecystectomy for gallbladder cancer. But what we found to be interesting is that if you looked at the overall incidence of N1 disease, it was about 30%. So 1 in 3 patients had lymph node metastases. Well, you might say, well, that's not fair because half of the patients didn't even have a lymphadenectomy, and so they had NX disease. Well, I would submit to you that even if we take the best case scenario and suppose that every patient who did not have a lymphadenectomy had N0 disease, the incidence of lymph node metastases would still be about 20%. And these data have been corroborated by multiple other investigators. So we know now that the overall incidence of lymph node disease is probably in the range of about 20 to 30%. And I would submit to you that we should be doing lymphadenectomy because we do it for other diseases, right? We do it for colon cancer, and we all generally accept that we don't do it for colon cancer for therapeutic reasons. We do it for staging reasons and to inform our prognostic stratification of the patient. We also do it for gallbladder cancer, and we do it for fibrolamellar cancer. So similarly, for intrahepatic cholangiocarcinoma, the nodal status is extremely important in prognosticating the patient. And the nodal disease is, in fact, one of the most important prognostic factors. So luckily, I had the benefit of being part of the 7th edition AJC staging group. And in the 7th edition, they adopted the proposed new staging for intrahepatic cholangiocarcinoma. And you can see that here is that in the 7th edition, T1 disease was solitary, T2A and T2B was a solitary or multiple with or without vascular invasion, and then T3 and T4 were more advanced disease. The thing that was interesting in the 7th edition is that we took out tumor size, right? As many of you know, for hepatocellular carcinoma, 5 centimeters is a cutoff that was used in staging. But for intrahepatic cholangiocarcinoma, we took out tumor size. And that was because early on in our experience, most patients presented with late disease, and they had very large tumors. So our cohort was up on this flat part of the line. But as we accrued more patients into our international collaboration, we actually saw more patients with early stage disease. And as we accrued more patients with early stage disease, we were able to go back and redo some of our analyses, and we actually found that indeed there was a breakpoint at about 5 centimeters with regards to the hazard of death. And we published these data in JAMA Surgery, and we included in our nomogram tumor size. And you can see here that the nomogram is heavily weighted to 5 centimeters. So you can see that there's a big difference among patients who have very small tumors, but once you get over that 5 centimeter threshold, there's really a clustering in the nomogram where size over 5 centimeters seems to matter less. So that is why in the 8th edition, we revised the staging to re-include tumor size as a cutoff. And the revision of the 8th edition has T1 disease as being divided into T1A as less than 5 centimeters and T1B, which is greater than 5 centimeters. And then the T2 category was modified to reflect the equivalent prognostic value of vascular invasion and multifocal disease. And here is the new 8th edition ICC staging, which we validated using an external data source, both from institutional data and nationwide data in the SEER data set. So moving on to treatment. These patients can be very challenging to treat. Many of them present with late disease, large tumors. Here's a patient with a large tumor in the central portion of the liver, abutting the umbilical fissure. It's completely taken out the anterior posterior sectoral branch and is abutting the posterior sectoral branch of the right portal vein. Most of these patients are going to need major hemihepatectomies or even an extended hepatic resection, as can be seen here. And the other thing that can be noted is that the margin on some of these resections can be quite challenging. And here's the reconstruction. So we put together a large international group, and it's even grown more from this group here. And I want to highlight that Dr. Menta was very instrumental in helping us with the Swiss data when he was alive, and he was a great colleague and friend. So I want to just point that out as we're here in Geneva today. These patients don't do well. After resection, even with curative intent resection, the 5-year overall survival is 30%. And I would argue that that is not too dissimilar to pancreatic cancer, right, where we say the 5-year survival is in the range of maybe 25%. The incidence of an R1 margin in curative intent surgery, at least in our international experience, is about 20 to 25%. So relatively high, 1 in 4, 1 in 5, and then we have over 2/3 of patients being dead by 5 years. Now, why did they die? Well, it's quite obvious. That's because they tend to recur. And if you look at the patterns of recurrence, over half of patients will recur within 2 years of their operation. So these are major operations with not inconsequential morbidity. and over half of patients will recur within 2 years, which is somewhat sobering. And if we look at the pattern of recurrence, about half of patients will recur with only intrahepatic disease, and the other half will recur with some component of extrahepatic disease. And as I'll go on to show and discuss is I think these data are why adjuvant therapy is so important. Because just like colorectal cancer and metastatic disease, the real advances are going to come when we have more effective systemic therapy to treat this disease. And also, I know Mike D'Angelica spoke yesterday about hepatic artery infusion pump therapy for these patients, either in the setting of inoperable disease or even in the adjuvant setting. And I think based on this pattern of recurrence, whereby roughly half will recur with only intrahepatic disease, I think hepatic artery infusion therapy as an adjunct to surgery at least is an interesting concept and probably should be pursued in the future. If you look at the risk of recurrence, those patients who have a single lesion and no evidence of lymph node metastases, their incidence of recurrence is 40%. But those patients who have multiple lesion or lymph node metastases, virtually all of them recur. And that's why if on a pre-operative PET, patients are found to have lymph node disease, I typically offer them chemotherapy first because I know that their biology is very bad, and I do not want to do an extended hepatic resection on someone only to have them recur 6, 12 months afterwards. I'd rather treat them preoperatively with chemotherapy, let the biology sort itself out a little bit, and then take them to the operating room if indeed their biology seems to be favorable. If you look at the pattern of recurrence, as I mentioned, roughly half will recur in the liver, but I do want to draw your attention to about a third of patients will recur in the lymph nodes. So I will argue, and this is somewhat controversial probably, that perhaps there is a therapeutic benefit of doing the lymphadenectomy also, because recurrence of hilar disease, especially bulky hilar disease, can be somewhat difficult to manage and can sometimes cause biliary obstruction. And I think clearing the nodal basin at the time of the initial surgery will obviously decrease the incidence of nodal recurrence. And really, performing a lymphadenectomy does not add much time to the operation. And if we're doing it for fibrolamellar or gallbladder cancer, I definitely think that we should be doing it for intrahepatic cholangiocarcinoma. So I just want to touch a little bit on some adjuvant therapy for patients who have intrahepatic cholangiocarcinoma. Given the grave prognosis of these patients, even with curative intent surgery, we need to change our focus and turn our focus to systemic therapies and more aggressive local regional therapies. So this is the ABC study, Advanced Biliary Cancer Study. And this was a study in patients who had advanced stage 4 disease. So not patients with operable disease, but advanced disease. And this looked at monotherapy with gemcitabine versus doublet therapy with cis versus gem. And in this study, as all of you likely know, is that there was a benefit to doublet therapy with cis-gem with the doubling of the median survival from 4 to 8 months. So these data, which were obtained in patients with stage 4 disease, have been extrapolated into the adjuvant setting, if you will, for at least many of our patients in the United States. So some patients were receiving adjuvant gem-cis, especially if they were believed to be high risk, such as having nodal disease. Well, as you all know, more recently there have been data published and presented in the true adjuvant setting, in particular the BILCAP study and the Protege 12 study. And in the BILCAP study, which to my knowledge has only been presented in abstract form and as a presentation at ASCO, what the investigators found was that adjuvant capecitabine had a pretty significant effect in the adjuvant setting, whereas patients in the observation group had a median survival of 36 months, whereas patients in the capecitabine group had a median survival of 50 1 month, and there was an associated 25% lower chance of death with capecitabine. So these data have been very quickly and widely embraced by many in the oncologic community to suggest that patients who have cholangiocarcinoma, who have intrahepatic cholangiocarcinoma as well as extrahepatic, should be treated in the adjuvant setting with capecitabine. Interestingly, though, the Protégé 12 study that looked at adjuvant GEM-OX was a negative study and showed that indeed patients who received GEM-OX versus surveillance had no real difference in overall survival. 30 months with GEM-OX, 22 months with surveillance, with an insignificant difference in the hazard ratio. Now, I would say, at least to my eye, that there are some differences in the patient populations in these two trials, particularly in Protégé, that the majority of patients were node negative and had an R0 resection. So one may argue that this was a lower risk group, and therefore that is why there was no difference, because one would expect the therapeutic benefit to be more obvious in patients who are at higher risk. And indeed, in the BILCAP study, the incidence of patients who had node-positive disease was higher. So perhaps the underlying groups were different, and that is why we saw a difference in the adjuvant setting for capecitabine versus GEM-OX. Although I will say that we'll have to see the full publication of the BILCAP before we can have a full opinion on where we stand for adjuvant therapy for intrahepatic cholangiocarcinoma. With regards to radiotherapy, I think that the role of radiotherapy is limited. I typically would only use it for patients who had a focal R1 margin, and I'm not even really sure I'd use it in that setting. I think, though, radiation therapy can be thought of for patients with inoperable disease. And currently, in the United States, there is an open trial looking at GEM and CIS with or without radiation therapy for those patients who have inoperable localized disease. So this can be considered for that subset of patients to enroll them to this clinical trial. And then finally, as I mentioned, I think there is a role for intra-arterial therapy. Many institutions do this on using a catheter-based approach rather than a pump-based approach. These are some data that we published while I was at Hopkins, and this is a multi-institutional study, retrospective from University of Pittsburgh, Northwestern, Memorial Sloan Kettering, Mass General, and Hopkins. And in this study, for those patients who had advanced and operable intrahepatic cholangiocarcinoma who were treated with intra-arterial therapy, and it was really dealer's choice. It could be Y90 at Northwestern, or it was bland embolization at Memorial Sloan Kettering, and then it was traditional TACE at Johns Hopkins. You could see that at least in a subset of patients who had a complete or partial response, there were some individuals who derived a survival benefit. And so I think that these data are provocative, obviously retrospective, but perhaps do suggest a role for arterial-based therapy and even pump-based therapy for those patients who have inoperable disease. And I know that Mike, again, has presented some data showing quite dramatic responses for patients with inoperable disease in the liver after a pump had been placed. So in conclusion, hopefully what I've shown you is intrahepatic cholangiocarcinoma is a very grave disease, that the incidence is increasing, that that the cornerstone of therapy is still surgical therapy, but recurrence is the rule, not the exception, and the case fatality rate remains high. I've identified some prospective open clinical trials, and I do think for this disease that as we begin to understand the underlying molecular pathogenesis of this disease, that personalized therapy will become more and more important. So with that, I'll conclude, and I'll be happy to answer any questions. Thank you. Yes, Scott. So laparoscopy, I do not do a diagnostic laparoscopy before I explore these patients. There's not much literature on that. I think that the yield on that is low, so I don't do it. I do think that these cases obviously can be done laparoscopically. I was talking to Dr. Luca Eldrighetti from Milano last night, and Luca has done over 100 intrahepatic cholangiocarcinomas laparoscopically. And he does a full lymphadenectomy, and he mentioned last night that his data will be published, I believe, in HPB in the coming month, and he showed that compared to open, the oncologic outcomes, the lymph node yield was comparable laparoscopically versus open. So with regards to N2, I don't do lymph node sampling when I'm in the operating room, virtually for anything. I kind of think when I kind of make my decision preoperatively, and I go in and I typically do it. I do the lymph. I don't send it off, and because if you send it off, even the yield is going to be low. All they're going to do is bivalve the node and see if there's cancer there or not. And even if there was cancer, I'm not sure I would stop, right? And I kind of facetiously say, we all do the Whipple, right? And we all know the Whipple has bad prognosis, and that doesn't stop us from doing the operation. So I think, kind of a rigorous preoperative workup, trying to identify patients who have multifocal disease, who have lymph node metastases preoperatively, treating them preoperatively with chemotherapy. But then, I think extrahepatic disease like carcinomatosis or something, which at least in my experience is very rare, would stop me. But otherwise, I'm going to do a lymphadenectomy and I'm going to proceed with the resection at the time of surgery. Yes. Yeah. Yeah, please.
It's a great talk, actually. Thank you very much. I have two questions.
Yeah.
The first one, you said you tried to rule out the liver metastasis from colorectal cancer. Mm-hmm. So how often actually you do the colorectoscopy or up GI scopy for the patient? Because afterwards you mentioned turned out most of patients actually do the PET scan. So if
I'm sorry, most patients what?
PET PET scan.
Oh, yeah.
PET CT. So if you do the PET CT, maybe you can save some kind of colonoscopy or up GI scopy. This is a question.
So let me answer that first. So I agree. Yeah. I mean, so for colonoscopy, typically I make sure that they're up to date. They've had a colonoscopy in the last 10 years. It depends on their age. And then also based on their symptoms. If they have colonic symptoms and change in stool caliber blood, then they'll get it. But and the same thing goes with the upper GI. I mean, I rarely do the EGD. I just make sure that their colonoscopy is up to date. But I think your point is well taken. If you get the PET scan, if you identify something,
Okay. The second question is that in a decade, actually 5 years survival is not really increasing, about 30% maybe. I see a report from 1997 or something. It's 29% of 5 years survival. You mentioned a lot of adjuvant therapy, including chemo, radiotherapy, even PD-1, PD-L1, and that how you comment on that contribution to the 5 year survival.
Yeah, so I guess a couple things. One other paper that we published using a different statistical method was it's called a non-mixture cure model. Because you have to remember that when we calculate these Kaplan-Meier curves, this is typically what's called a mixed model, because there's people in that curve, some survived, some didn't, right? So you're just basically, including this mixture. But if you approach it statistically in other ways, and you look at, true survivors, long-term survivors with this disease is probably in the range of about 10 or 15%. So I agree, very poor prognosis. I would argue it's just like colorectal cancer, right? We perfected the operation, but we didn't really see the overall survival curve move until oxaliplatin, irinotecan, cetuximab, bevacizumab, right? When more effective cytotoxic chemotherapy came into play, then that, increased overall survival, and then perhaps even paradoxically increased the role for surgery, right? Some people thought it was going to decrease the role for surgery. Actually, it has an increased role of surgery. And I think similarly for intrahepatic cholangiocarcinoma, until our medical oncology colleagues, quote unquote, catch up, the survival is going to remain roughly the same.
Okay, thank you.
Yes, last question, and I think other crowds coming in.
Yeah, I'm Razak from Kuala Lumpur. Is there a role of liver transplant in intrahepatic HCC?
Yeah, so that's a good question. In the practice guidelines, we address that, and we said currently right now that it should only be done on a protocolized basis. If you look at the small amount of literature that's out there, typically the outcomes are poor, and that's largely because if you look at the patterns recurrence, 50% of patients will recur outside of their liver. So there are some data presented on transplants where incidentally a small intrahepatic cholangiocarcinoma was found on the explant, and those patients do well. But transplanting patients with large intrahepatic cholangiocarcinomas, the results have been poor. So, okay, I think with that we'll have to conclude, and I'd like to thank all of you for coming this morning.